So as you can see in our screens today, we'll be covering the pathologies of the hepatobiliary system. And it will be a very important session given that we've already covered the pathologies of the gastrointestinal system. Can you let me know when my network lags or maybe if you can't be able to hear me well? Yeah, so as you can see, that's background image. There is the liver on this end, then you can appreciate this side of the yeah, this is a pancreas. You can see the head of pancreas, some pancreatic ducts. You can be able to see the gallbladder here. And then you can be able to appreciate liver cancer, pancreatic cancer, head of cancer, pancreatitis, and biliary stones, gallstones that we usually talk about. Yeah, so that's me. I hope you still know me. Uh, and what are we supposed to cover today? We are supposed to review We're supposed to review the anatomy and physiology of the hepatobiliary system. We're supposed to also try and look at the pathological basis and clinical manifestation of jaundice. Maybe you've seen a person with yellow eyes, and then even if the person maybe washes the eyes, they're still yellow, and then goes to the hospital. Person is told he has liver issues. What is this yellow eyes that we usually see? And the other one is to explore the pathology features of liver disease. You know the liver, so we are going to recover, to review the anatomy and physiology of the liver. We are going to check on the pathological features of the liver. Then we're going to check on the mechanisms and systemic features of portal hypertension. Explore the pathology and clinical features of the biliary and pancreatic disorders. And then we'll get more into this, but we'll try to see the investigations, treatment, and management of these hepatobiliary diseases. So starting with the liver, as we can see here, and the reason you saw it in your anatomy, that this is a liver, it has two lobes, the right lobe and the left lobe. You can see the structures of the portal triad. So you can this is a hepatic vein, this is a hepatic artery, and this is a bile duct. This hepatic vein is really the portal vein that goes to the liver. And now you can see the biliary tree. Maybe in terms of anatomy, this liver is found in the abdomen, but where specifically in the abdomen, it's found on the right upper quadrant. So you'll divide the abdomen into four quadrants. There is right upper quadrant, left upper quadrant. There is no lower up the left lower quadrant, and there is the right lower quadrant on either side. So the liver will be found on the right upper quadrant in the abdomen. And to be very specific, the liver is the largest internal organ. It's actually the largest gland that you have in the body. And it's divided into majorly two lobes, the right and the left lobe. Though we have two small lobes, the caudate and the quadrate lobes, you can be able to appreciate them on the anterior aspect. You can only see them from the posterior aspect, the caudate and the quadrate lobes. Then we have the functional lobes. And so remember, the liver is divided into anatomical lobes and functional lobes. So anatomical lobes is what we saw, the right and the left, just by the anatomy, like the structure. But now we have functional lobes, where the liver is divided into, into a number of quadrants, eight of them from segment number one to segment number eight, based on vascular supply. And then this liver is covered by Gleason's capsule, and this Gleason's capsule is a connective tissue covering the liver, and also that capsule enables the liver to get attached to the diaphragm, to to the inferior vena cava, just to make sure that the liver has support. And then, of course, the liver has ducts. Given it's a gland, it will have ducts. And these are biliary tree that we should talk about. So the duct of the liver, together with the gallbladder and the pancreatic duct, usually make the biliary tree. And this is what you can be able to see. So usually have And actually, this is something that is examinable, that I would like us to appreciate in our exams, that the liver has the right and the left hepatic ducts, the right and left hepatic ducts, which join to give us the common hepatic duct. Then this common hepatic duct is joined by the duct, this cystic duct coming from the gallbladder. This is the gallbladder, give us the common bile duct. And then the common bile duct is joined by the pancreatic duct to form this hepatopancreatic body of water that drains into the duodenum, that we will see. So that's the biliary tree. So can you make sure that you can be able to describe this biliary tree where you have left hepatic ducts, the common ducts. This common duct has cystic, joined by cystic duct to become common bile duct. The common bile duct is joined by pancreatic duct to give us hepatopancreatic ampulla of vata. And now that's the anatomy. Now we need to go deeper to check on the histology of the liver. And this histology of the liver has three types of lobules. But today we'll check on one important type of lobule, which is classical hepatic lobule. So it's called classic hepatic lobule because it's one hexagonal in nature, and then it has one central vein. This one central vein at the center, surrounded by six, it's hexagonal because surrounded by six portal triads. So the portal triad has the portal vein, the bile ducts together with the hepatic artery. So even this portal triad that you're seeing here will contain the three. So each of the three give a portal triad, a portal triad, a portal triad, a portal triad, six of them. Then at the center you have a central vein. So that's the classical hepatic lobule. In your histology exam, you can be told to draw about you can be told to draw this classical hepatic lobule. Then, as you saw, the corners contain portal triads, and these portal triads will contain a branch of portal vein. They will also contain hepatic artery. They will also contain bile ducts. So that is what now this portal triad will contain. And that is histology, as I presume you already know, it's the histological study of, or the microscopic study of organs. And then, so this is the liver. Go to microscopy, this is what you have as microscopy. We need to study it in terms of the cell types. So what are the cell types that will be found in these hepatic ducts or in the liver? One, I would like us to know the function, not to just know the cell types, where we have one hepatocytes. These hepatocytes actually they form the largest number of cells in the liver, with the function there. Then you have Kupffer cells. These Kupffer cells, they act like the immune cells of the liver. Then you have the stellate cells of Ito, usually called stellate cells of Ito. And then you have the endothelial cells. These endothelial cells usually line up the portal venules that are present in the liver. So for us, I'd like us to know the four cell types. Also, it can be better if you can know the functions of these cells, but I wouldn't delve much into that, but just know the cell types of the liver. Those are important things that I'd like us to know. And then it is also important for us to appreciate the blood supply of the liver, given that this liver, it has it has dual blood supply, like it has two structures bringing in blood into the liver. And one of them is this portal vein that brings 75% of blood. And this blood from the portal vein comes from gastrointestinal tract, especially the stomach, the duodenum, the small intestine. That's where the blood comes from. 75% of blood supplied to the liver. The remaining 25% comes from hepatic artery. This hepatic artery is a branch of celiac trunk, and this celiac trunk is a branch of abdominal aorta, as you can see here. So celiac trunk is usually hepatic artery. Then this common hepatic artery divides into the right and the left hepatic arteries. Yeah, and then now in terms of venous drainage, we'll have the central veins drains into hepatic veins. Then these three hepatic veins drains inferior vena covered. So this is just a review of anatomy that we've already covered. And then now we go to the gallbladder, which is a very important structure, as we can see here. And for this gallbladder, it has parts. It has a fundus, body, and neck. As you can see, the fundus is around here. So these are fundus around this part. Then the remaining aspect is the body, and then it has a neck. So this neck joins together with this, this neck becomes a cystic duct. Then the cystic duct joins the common hepatic duct. Remember this side you have the right and the left hepatic ducts, giving us common hepatic duct. Common hepatic duct joins together with the cystic duct to become bile duct. I hope you still remember that. So what is the function of this gallbladder? It has three major functions actually. And if you get these three major functions, you'll be good. One, it produces. Number two, it stores. And number three, it concentrates bile. So produces, stores, and concentrates bile, the important functions. So in terms of cystic and biliary relations, I've already told you about the cystic duct plus common hepatic ducts give us common bile ducts. Then ideally, this now common bile duct is in close relation with the pancreatic head. You'll see the pancreas in a few minutes. So these are some of the clinical correlations that we'll go through, like gallbladder inflammation, portal hypertension, and common bile duct obstruction that can come across due to pancreatic cancer and such things. But we'll go through that in a few minutes. Yeah, so this is what I was talking about. As you can see here, you can appreciate the fundus. They are color coded in brown. Then you can see the body color coded in green. Then you can see the neck color coded in yellow, giving us the cystic duct, joined by the common hepatic duct to give us the common bile duct, as you can see there. Okay, so let's go to the pancreas. And now to make things to come into play, because with the gallbladder there, here we have the common bile duct. This is that to give us the common bile duct. The common bile duct joins together with this major pancreatic duct of the pancreas to give us the ampulla of fat that drains into the duodenum. I hope you can be able to appreciate this opening here. So what are the parts of the pancreas? As you can see, you have the head, which is this. You have the neck. This is the neck of the pancreas. This is the body of the pancreas. And then you have the tail. Also, you usually have an acidic process. You have an acidic process of the pancreas that is here. And you can see it's actually on this second part of the duodenum. Regarding the ductal system of the pancreas, I presume this one has a better one. You can appreciate this is a main pancreatic duct. Main pancreatic duct of Nissan. Then there's a small accessory duct of Santorini. Just note it has a major pancreatic duct and a small pancreatic duct. The major pancreatic duct of Nissan and this accessory duct of Santorini. So all supplies this pancreas of ours. One, it has the head together with the superior aspect of the body and the neck is applied by the superior and inferior pancreatic duodenal arteries. And then the body and tail, so you have the body and the tail is applied by the splenic arteries. Then in terms of histology, you can see now the various parts made process of the pancreas. This is the head of pancreas, the neck of pancreas, You can see the body and the tail. And then you can see this duodenum here, going to become the ileum, the jejunum, then ileum. And then you can appreciate this as spleen and the various blood vessels here. So it has two parts. The pancreas has two histological parts. It has an exocrine pancreas. It has an endocrine pancreas. So the exocrine pancreas has produces digestive enzymes. So if you've heard about pancreatic amylase, if you've heard about pancreatic lipase or pancreatic proteases, they come from the exocrine pancreas. And actually, they form like 90% of the pancreas. Then you have endocrine pancreas, which is known as the cluster of cells are found together known as islets of Langerhans. And that's on a higher magnification. You can see this structure here. These are islets of Langerhans that has the various cell types. You can see alpha cells, beta cells, some PP cells. And these beta cells produces insulin, and alpha cells produces glucagon. And that's where now, today we are not covering more about endocrine system, because the endocrine system, we'll talk about it when we going through endocrine pathology. So we won't talk about diabetes mellitus that is being caused by the deficiency of insulin production by the beta cells, or maybe if there is resistance in terms of the insulin produced by the body. So that's it. I think we are going to start now. Given that you already have a basis of what, or a review of our anatomy and physiology of the pancreas, gallbladder, and the liver. Now we are going to review and change gears. And start about and talk start to talk about jaundice. I hope at this point you can be able to appreciate differences between these two images. Like on this side, on the lighter side of this image, like this person is like the eyes, you can see the conjunctiva is actually normal. On this other side, you can appreciate there is yellowing of the eyes. And that yellowing of the eyes is what we describe as jaundice. Is what we describe as jaundice. So what causes jaundice? That means given that you're covering it today, it means it's supposed to be covered by what we're talking about today. So jaundice by definition is a yellow discoloration of skin, sclera, and mucous membranes, as you can see there. So it's a yellowish discoloration of the skin, sclera, and mucous membranes. And this skin can be on the palms, can be most palms or maybe plantar aspect. But where you can see jaundice well is actually on the palm of your hands, your eyes, that is the sclera, and also on the mucous membranes, that is the tongue, the lips. You can be able to see it there. And with jaundice, for us, it's better to appreciate that we have prehepatic jaundice. So prehepatic jaundice is the jaundice that is being caused by other pathologies that are not in the liver specifically. So maybe hemolytic anemia and such things. So hepatic jaundice is being caused by others by other pathologies, not specifically by the liver. So it's prehepatic. Then you have also the hepatic jaundice. And this hepatic jaundice, where now we have hepatocyte injury. Remember, we talked about one of the cell types in the liver being called hepatocyte. So hepatic type of jaundice is actually a mixed type of jaundice where you have increase in unconjugated and conjugated bilirubin. Bilirubin is one of the byproducts of the liver components. And so due to the hepatic injury, the hepatocyte's injury, there is impaired uptake, conjugation, and excretion of this bilirubin. So we have prehepatic, hepatic is the liver itself. Then posthepatic means we've talked about the various ducts. So posthepatic jaundice happens when there is obstruction to bile flow. So it can be due to either the gallstones that are present, can be due to trauma, can be due to cancer, leading to obstruction of ducts to allow the flow of bile. So the three types of jaundice: pre-hepatic and post-hepatic jaundice. For us, just know the types and then you know the clinical correlation. So one, jaundice plus dark urine indicates conjugated bilirubin. Then the person might have pale stools to show that there is reduced bile in the intestines. And then also the person might have pruritus. Pruritus is actually itching due to bile deposition in the skin. So when bile is deposited in the skin, once again, we've talked about this, skin can undergo yellowing. So when that bile is deposited on the skin, that might be pruritus. Yeah. So that's about jaundice. As you can see, the features. So in an exam setting, what can I ask you? Actually, jaundice is an indication that there is either a pathology in the liver or structure related to the liver in that regard. So the liver can't be able to carry out its normal functions because of that pathology. So you can't have jaundice as a disease, but you can have jaundice as a presentation of an underlying liver or associated structures. So let's now go to the liver itself. So remember, even in previous sessions we talked about inflammation and even the liver is called, it's a hepatic, it's hepatic in nature. It's hepatic. So what is the inflammation of the liver? It's hepatitis because the liver is inflamed. So you can have two types of inflammation of the liver. You can have acute inflammation, you can have chronic inflammation. So what you are starting to go through right now is acute hepatic inflammation or acute liver inflammation. So that is acute hepatitis. So what is the definition of acute hepatitis? So the definition of acute hepatitis is that it's acute inflammatory injury of hepatocytes that comes across due to that actually has reversible structural and functional changes. So what makes it acute is that it happens for a short time and then it's actually reversible. So you can be able to reverse this inflammation of the liver. And as you can see from the definition, it leads to what happens is that it leads to if there is structural and functional changes of the liver. So what is the pathology in this acute hepatitis? One, there is diffuse hepatocellular injury with inflammatory response. Remember, I told us about there is hepatocytes. So injury to hepatocytes is what we are calling hepatocellular injury. Of course, due to inflammation in hepatitis, there is inflammatory response, and then there is globular architecture that is generally preserved. What is the morphology of this acute hepatitis? And actually, this is now what I will ask in an exam setting. Is one, the liver is enlarged, it's inflamed, it has swollen, it's inflamed, it's enlarged, and then it's tender liver, that what is usually known as now hepatomegaly. And then there is hyperemic parenchyma. Any place that I told you that there is an inflammation, the tissue is usually hyperemic. Hyperemic means it's reddish in color, like it's inflamed. And then clinical correlation, as you can see in this, you can see there is fever, person has loss of appetite, there is nausea and vomiting, there is abdominal pain, there is weakness and fatigue, and there is joint pain. And that is not being shown here. There is jaundice, of course, hearing on the skin, malaise and anorexia. There is elevated transaminases. These elevated transaminases are actually liver enzymes that are there because of hepatic injury, vascular injury. So, can CST and ALT are there. It can lead to us having fulminant hepatic failure, and also it can progress to chronic hepatitis. So, what causes this um, acute hepatitis? One, viral infection, hepatitis A, hepatitis B, C, D, and D. They usually cause hepatitis. But the point is, that's the reason I'm usually told to go and vaccinate, especially we as health workers, you're supposed to be vaccinated against hepatitis B specifically. Yeah, so if you're not treated, if you're not vaccinated, can you look for a way to be vaccinated against this? And you can see it can progress to fulminant hepatic failure, like the liver stops to function and then can go to progression to chronic hepatitis. And this is what now we talk about. When talking about chronic hepatitis, this is what we are talking about. That chronic hepatitis is persistent hepatic inflammation for more than 6 months. The other one was just acute, a very short time of maybe a week or so, leading. So this chronic hepatitis of inflammation of the liver leading to progressive fibrosis, as you can see this. So this is chronic hepatitis. There is fibrosis, changes in the liver architecture, as you can see here, and there is architectural distortion. So what is the pathology in chronic hepatitis? We've mentioned about there is damage to the liver cells, which are hepatocytes. So due to chronic hepatitis, there is continuous inflammation. There is continuous hepatic injury with fibrosis progression and disruption of normal lobular structure. What is the morphology? Irregular liver surface. As you can see in this, you have irregular liver surface, and then there is progressive fibrosis that actually is found in the portal triad, as I showed us earlier. Clinical correlation, ideally, they'll be almost the same features as acute hepatitis now, but of course, signs of chronic liver disease will start to kick in, such as fatigue, hepatomegaly, and actually it may progress to cirrhosis, as you can see here. So if this chronic hepatitis is not treated, it will go to cirrhosis, liver cirrhosis. And then if this liver cirrhosis is not treated, you'll have liver cancer, that is hepatocellular carcinoma, as you can see here. So the complications are actually, so let me mention about risk factors of this. So the risk factors for chronic hepatitis and acute hepatitis is one the viral infections that we talked about, hepatitis A, B, C, D, E. It can be predisposed to by alcoholism or maybe infections, some bacterial infections in that regard. So if you have chronic hepatitis, what will you have as complications? One, it may progress to cirrhosis, as you can see here. Two, it will lead to portal hypertension, and I'll show you why portal hypertension. And then the other thing is that it will lead to hepatocellular carcinoma, as you see here. So it can lead to hepatocellular carcinoma. So kindly get vaccinated against hepatitis. Yeah, so what is liver failure? So if we're done with inflammation of the liver, we talked about chronic and acute hepatitis. So what is liver failure? So by the name itself, like it's actually a liver that is failing. Why? Because it has lost its normal functions. So by definition, liver failure, so this is a normal liver, you can see this image. So it will change from this normal image to something like this. That is a liver that has already lost its function. So definition of liver failure is severe impairment of hepatic function. So the liver has lost its hepatic functions. And what are some of these hepatic functions? One, synthesis. It has synthetic synthesis of proteins. All the proteins of the body are synthesized in the liver, except very few. It has metabolic functions. It has detoxification capacity. Um, and this impairment is actually what you're talking about as liver failure. It can't be able to carry out its functions. So it can occur as acute liver failure on a short time. It can be chronic liver failure, and that is what now is called as end-stage liver disease. So liver failure is actually a liver that has lost its functions in that regard. What is the morphology of this liver? One, in acute liver failure, you have an enlarged liver, that is hepatomegaly. Hepatomegaly is an enlarged liver, or sometimes you can have a shrunken liver with soft necrotic parenchyma. So we talk about it can be enlarged, can be shrunk, it can shrink depending on the cause of liver failure. Then number two, chronic features of liver failure. So this is what you'll see when you do the postmortem or maybe during our pathology lessons. You'll appreciate that the liver will be small, shrunken, nodular liver that actually we have yellow discoloration, as you can see here. So that is the pathological features that we'll be able to appreciate in a liver. Then for clinical correlation, of course, jaundice, coagulopathies, hypolipidemia, hepatic encephalopathy, giving that the person presents with confusion and coma. Yeah, so I think with that, I'd like us to, yeah, so as we had mentioned earlier, we can appreciate the clinical symptoms. One, as I had alluded earlier, about jaundice and coagulopathies. Coagulopathies is actually increased bleeding tendencies. So the person, basically, because you can remember there is that coagulation profile, and the various proteins, maybe you've heard about thrombin, fibrinogen, fibrin, all of them are actually proteins that are produced by the liver. So if the liver has failure, it has lost its functions, what happens is that it will it will lead to loss of liver functions, and one of the liver functions is production of coagulation factors, and the coagulation factors lead to blood clotting. So the person has increased bleeding tendencies. The other one is hypoalbuminemia. One, albumin is produced by the liver, so the person will have hypoalbuminemia, and then that will lead to edema. Edema is increased swelling of the body, that can be in the limbs, lower limbs and upper limbs, can also be in the ascites. Ascites is actually the distended abdomen, and also the person can have hepatic encephalopathy, coming across with confusion, coma, and such things. So, what are some of the complications of liver failure? One, cerebral edema. Remember, we've talked about hypoalbuminemia, and hypoalbuminemia leads to edema, and this edema can lead to cerebral edema. And remember the other thing, one of the functions of the liver is actually detoxification. And detoxification means it removes the increased nitrogenous compounds that are found in the body. So what happens if the ammonia, if the urea that is found in the body increases, the person will have hepatic encephalopathy. And this hepatic encephalopathy comes across with confusion, coma, the person can have seizures, loss of consciousness due to liver failure. And it can lead to cerebral edema, like that is the brain having edema, can lead to sepsis, and it can lead to multi-organ failure. So if you have liver failure, it can lead to heart failure, it can lead to kidney failure. Yeah. Okay, so that's majorly about the liver, and let's appreciate what is hepatic encephalopathy that you talked about. So hepatic encephalopathy is a cause of liver failure. So hepatic encephalopathy now by definition is reversible. So one, in terms of definition, reversible, it's neuro, that is related to brain and the cerebrum, and talk about the nervous system. So neuropsychiatric. So the person will have confusion, psychiatric related features due to accumulation of neurotoxin in liver dysfunction. So the liver was supposed to be excreting a few things, but because it can't be able to function well, it will lead to liver dysfunction, leading to global cerebral dysfunction. And that is what they're calling as hepatic encephalopathy. And you can see the pathologies here. So the person in mood and personality swings, the person can become irritable, the person can worry about anxiety, memory, concentration and thinking, insomnia, lack of sleep, and lack of muscle coordination and motor function problems, and actually loss of autonomy and ability to care for oneself. Those are some of the features of this hepatic encephalopathy. So what is the pathology? The pathology here is that the failure of the hepatic or the liver detoxify the substances that are being taken into the liver, leading to accumulation of ammonia and other neurotoxins. So ammonia is one of the neurotoxins. Maybe talk about urea and some other nitrites. And that leads to one, because they're accumulating in the body, they will break off, they break into the blood-brain barrier and get into the brain, into the cerebrum, leading to this cerebral or the neuropsychiatric features. So clinical correlation, confusion, the person can undergo coma. Atelectasis is one when the person is having tremors of the hands or maybe of the lower limbs. Then there is altered sleep pattern, that is insomnia and irritability. Person can become very, very much irritable. And what are some of the precipitating factors to this hepatic encephalopathy? Is one, when you have liver failure, but also you have gastrointestinal bleeding, or maybe you have infections. Maybe respiratory infections can be gastrointestinal infections. The other one can be high protein loads. So remember, protein gives rise to nitrogenous waste. And this nitrogenous waste, one example is ammonia. So if you increase eating or maybe taking a lot of protein, that will lead to increase in production of ammonia and other neurotoxins, leading to hepatic encephalopathy. And also, if you have electrolyte imbalance, maybe talk about hyperkalemia, hypokalemia, or maybe lactic acidosis or such metabolic acidosis can lead to hepatic encephalopathy. Complications of hepatic encephalopathy, as we saw earlier, one, cerebral edema that presents with raised intracranial pressure, that will present the person with headaches, as we can see here. And then also there is risk of brain herniation, where now the point where the brain exists, the skull using the foramen magnum, it can be able to herniate because of the increased intracranial pressure due to cerebral edema. Then the other point that we can appreciate, the other thing that we need to appreciate today is, okay, apart from hepatic, so we talked about chronic hepatitis. So from chronic hepatitis, we go to liver cirrhosis. And liver cirrhosis, as you can see by definition, is actually a diffuse irreversible liver disease. So it has come from the state where it was reversible. Right now, it's irreversible liver disease that is characterized by fibrosis. So fibrosis means the liver is actually trying to heal, but now it's healing by deposition of scar tissue in the liver parenchyma and the regenerative nodules, leading to, once you are depositing scar tissue into the liver, you are regenerating the nodules. That means what's happening? You are actually damaging the liver architecture. So leading to architectural distortion. And as you can see here, this is actually a healthy liver that goes cirrhosis, hepatitis, giving us this liver here. So you can have compensated liver cirrhosis, that is, the liver can be able to regain its functions, and you can have decompensated cirrhosis, that the liver has lost its functions. So in terms of pathology, what happens is that there is widespread replacement of normal liver parenchyma, as you can see. So this is a normal liver, but now you can see this normal liver parenchyma here. So it's widespread. Almost the whole liver has had the issue. The other one is formation of fibrous septa dividing the liver into nodules, as we can see here. It's not as smooth as this one because it has the nodulation that is happening. And then there is disruption of the normal vasculature architecture. So the normal blood supply to the liver is compromised. And what will happen? One, shrunken or small liver. So it will be smaller in both compensated and decompensated. And then a nodular surface, as you can see in both of them. So it can be micronodular, that is, in terms of histology, you can appreciate a micronodular structure, and also a macronodular structure. And what are now the consequences of this liver cirrhosis? One, we saw there is disruption of normal vascular architecture. So that it means there is impaired blood flow to the liver. If there is impaired blood flow to the liver, it will present with portal hypertension. Hypertension, of course, there is hypertension, as you know, it's increased blood pressure. So as you saw, there was a vein that was taking blood into the heart, into the vein, into the heart, into the liver, called portal vein. So portal vein means there is occlusion of blood into the liver. So what happens? Blood that is coming from the small intestine, from the other structure accumulates, leading to portal hypertension. And then there is reduced hepatocyte function, and that can lead to liver failure, or sometimes can lead to liver carcinomas. So what are some of the features of liver cirrhosis? As we talked about jaundice, you can see here. The other feature of liver cirrhosis, you can see ascites. Ascites is due to, we saw here we have a liver cirrhosis. This liver cirrhosis, because it's nodular in structure and such things, so what happens is that you're supposed to be having fluid getting into the liver, but now that blood can't get in. So what happens is that it filtrates into the abdomen, giving you ascites, distended abdomen, ascites. And so when you do pathology, you appreciate that this abdomen has fluid, ascites. And then it can also lead to hepatomegaly in early stages, and then can lead to shrunken liver in late stages. And then also it can lead to splenomegaly due to portal hypertension. So portal hypertension will also affect the spleen, leading to an enlarged spleen. So what are some of the complications of this liver cirrhosis? But of course, you can appreciate, you can see you can have encephalopathies, have sparse body hair, you have spider-like feature that will appear of the skin on a spider angiomas. This muscle wasting, that is the muscles undergoes atrophy. Dilated umbilical veins, as you can see here. Then there is ascites, there is then palms, there is jaundice, that is yellowish skin, as you can see. So some of the features that you present there. So what are the complications of liver cirrhosis? One, portal hypertension. And this portal hypertension will occur as features as caput medusae. So you see this, you've heard about Medusa or that movie that looks like a snake or something like that. That is what will happen. So on the umbilicus, we usually have veins. So these veins really direct blood that comes actually is connected to the liver. So if you have blockage of the liver of the blood to the liver, what happens is that blood will accumulate on this blood, on these blood vessels on the umbilicus, giving you the caput medusae feature. The other one is that the esophagus is connected to the liver. So if the blood can't go to the liver, it goes to the esophagus. And also it can go to the rectum, giving hemorrhoids. So the blood supply to the liver is connected to the esophagus, also connected to the rectum. So if you have failure of blood go to the liver, it will give you esophageal varices, it will give you rectal varices or the hemorrhoids in that regard. Also, ascites, that is fluid accumulation due to portal hypertension and hypoalbuminemia, as you can see in this image. Hepatic encephalopathy, as we saw earlier, due to cerebral edema, due to ammonia accumulation and neurotoxicity. We talked about coagulopathies due to reduced clotting factor synthesis, leading to increased bleeding tendencies. And then it can also lead to liver cancer, also known as hepatocellular carcinomas, which a risk factor is cirrhosis that we talked about. Liver um, failure, cirrhosis, is the major risk factor to hepatocellular carcinoma. So what is portal hypertension, as I mentioned earlier, is actually, we can see blood from the small intestine, large intestine, usually go to the liver here. So what happens if you have now this liver blocking its supply to the liver? what happens is that you'll have esophageal varices, and also you'll have rectal or hemorrhoid veins, and you will have the rectal varices or the hemorrhoids here. So the pathology is that there is increase in hepatic resistance. Blood cannot come to the liver because the liver is compromised. So the blood there then decides to look for alternative way to flow. So it flows to the esophagus and flows to the rectum, giving us esophageal varices and also giving us rectal hemorrhoids. So the morphology is fibrosis compressing sinusoids and giving us regenerative nodules altering vascular channels. For the various types of portal hypertension, just know that there is prehepatic, intrahepatic, and posthepatic, just the same as jaundice. We have prehepatic portal hypertension, intrahepatic portal hypertension, and posthepatic portal hypertension. And the cause of prehepatic, that is before it gets to the liver, you have portal vein obstruction. So we have the obstruction happening here, maybe due to a tumor. Intrahepatic, we talked about liver cirrhosis as a major cause. And then posthepatic, that is obstruction of the hepatic veins or the inferior vena cava, leading to posthepatic portal hypertension. And you see, these things are actually can be able to protect yourselves by one vaccination against hepatitis, viral infection, bacterial infection, or you can avoid ingesting food poisoning, aflatoxins that is found in maize that is not well dried. You can avoid taking alcohol. You can avoid smoking to avoid having all these conditions coming in. And the clinical features of this portal hypertension you've talked about. You've talked about ascites, inflammation, accumulation of fluid in the abdomen. The other one is portosystemic collaterals, giving us esophageal varices, as we saw, carpal medusa, distended abdomen, that is dilated abdominal veins, and the rectal varices. We also see so that the spleen, because it's supplied by the portal, by the drains into the portal vein, will enlarge because of splenomegaly. So due to congestion, like blood pools in the spleen, giving it congestive enlargement, which leads to hypersplenisms. And the complications of this portal hypertension is variceal hemorrhages, as we saw in the esophagus and also in the esophagus and also in the rectum. Hepatic encephalopathy, as we saw earlier, and ascites leading to bacterial peritonitis. So clinical correlation, upper gastrointestinal bleeding due to hematemesis. So the person can be able to, when the person is vomiting, vomits blood. Abdominal distension, as we can see in this, and also signs of chronic liver disease. Yeah. So we've said that when you have ascites, it can lead to peritonitis. So what is peritonitis? By the word itself, you have peritoneum and you have itis. So what is peritonitis? Peritonitis is inflammation of the peritoneum. And most of the time it's bacterial infection, as you can see here. So this is a peritoneum. The normal healthy person will have this. And then inflamed one will have pus and fecal matter. So what is peritonitis? Peritonitis is actually inflammation of the peritoneal lining, as we talked about, due to infection, of course, chemical irritation, presenting a surgical emergency. So we have types of peritonitis, primary causes that no obvious, so it's not known what is the cause of peritonitis. Secondary cause due to perforation, for example, now you have an ulcer in the intestines leading to peritonitis, so that is secondary peritonitis, or you can have tertiary peritonitis, which is persistent or maybe recurrent infection giving us tertiary peritonitis. So what will you be able to see? One, the serosa of these intestines will be dull and congested. The other one is will be accumulation of purulent discharge, as you can see in this. because of bacterial infection. So purulent exudate, uh, that is pus in bacterial infection, turbid fluid and fecal contamination, as you can see this, because there is that inflammation that is happening, exactly a medical emergency. What are some of the clinical features of this peritonitis? There is severe diffuse abdominal pain. There is guarding that happens. There is fever and tachycardia. Remember, this is inflammation. So there is fever and tachycardia, and there is reduced bowel sounds. So reduced bowel sounds, fever and tachycardia, guarding, and severe diffuse abdominal pain. The person will be feeling pain in the abdomen. Complications, because it's actually bacterial infection, sometimes we'll see there is sepsis leading to septic shock. Septic shock is actually an emergency. Then you have intra-abdominal abscesses. We can appreciate like we have a mass here. So the mass swells is to intra-abdominal swell abscesses. Then multi-organ failure. So talk about the intestine, the stomach, the liver, the kidneys because of that. And that takes us to liver cancer. So what will you be able to see in a liver cancer before you go to the content? This are actually this liver. This is actually this is a normal liver architecture here, but now we have liver cancer here. And actually, it's diffuse liver cancer. It's actually fleshy mass of tumor that you can see. So this a tumor, this a tumor, this a tumor, this a tumor. Actually, it has invested in almost the whole liver. Definition of hepatocellular carcinoma or liver cancer. One, it's a primary malignant tumor of the hepatocyte cells that typically arises from setting of chronic liver disease or cirrhosis. So as we saw earlier, complications of chronic liver disease or cirrhosis is hepatocellular carcinoma or the liver cancer. How does it occur? Because of this hepatocytes trying to become or maybe to adapt to the changes in the liver functions, they become malignant. So there is transformation of hepatocytes with trabecular, pseudoglandular, or solid growth patterns. So the hepatocytes multiply uncontrollably, leading to liver carcinoma. So what will you be able to see in a post in maybe in pathology? You'll be able to see solitary large mass or multiple nodules. Also, you'll be able to appreciate. You can see this like there are multiple, there are many. It can be one solitary, it can be multiple. As you can see this image, and then they are yellowish in color. This ones you can see it well here, or sometimes greenish, yeah. So yellowish, greenish, tumor due to birth production in some cases. Then there is areas of hemorrhages and necrosis that are common. And there is vascular invasion. So you'll see one, there is blood. There's places that have blood supply, places that will have hemorrhages, yellow in color. Then the masses will be solitary, can be one or can be many, multiple. So what will you be able to see? One can be progressive weight loss, features of malignancies or cancers, progressive weight loss, hepatomegaly, the liver enlarges. The person will talk about pain that will be coming actually from the right upper quadrant and worsening jaundice. So the person will have features of jaundice, yellowing of the sclera, of the mucosa, of the hands. Yes. So we talked about liver cancer that will be able to be appreciated by increasing. These are just markers of liver cancer. Alpha fetoprotein, it can spread through blood, the lungs, and bone can also spread to the portal vein infection worsens the portal hypertension. Yes, so what is gall and stone? So gall for gallbladder, stones, presence of gallstones. presence of stones in the gallbladder, as you can see in this. So I think with that, I have actually finished talking about gallstones. Of course, you can see there is gallbladder here with stones in it, giving it gallstones. And these gallstones can also be present in the cystic duct, can also be present in the common hepatic duct or the common bile duct. You can see it also in the pancreatic in the hepatopancreatic duct of water, as you can see here. So what is gallstones? Actually, it's a formation of solid stones or calculi within the gallbladder of the biliary tree due to imbalance of composition of bile. And now, like maybe if there is an obstruction of the liver here, of this common bile duct leads to there is obstruction of flow of bile from the gallbladder and also from the hepatic ducts, leading to precipitation and formation of gallstones. These stones can be of different types. You can have cholesterol stones, you can have pigment stones. So just know the various types. So precipitation of bile leads to cholesterol stones, bile stones, and the pigment stones. So cholesterol stones and pigment stones. And how will these stones be looking like? They can be single or multiple. So they can be one or many. And they can vary. If it's cholesterol, they'll be yellow green. If they'll be pigment, they'll be black and brown. So depending on the color, um, they'll define that. And then the gallbladder, of course, due to the stones, it will undergo wall thickening. The mucosa, that is the innermost layer of the gallbladder, will undergo mucosal flattening or ulceration. And then there'll be chronic inflammatory changes in the long-standing disease. So clinical correlation, what will we be able to appreciate in a person with gallstones? One, they're usually asymptomatic. So at least it's high probability that most of us here have stones, but they are very few, or maybe they are silent. So often symptomatic silent stones, but sometimes they give us episodic right upper quadrant pain after fatty meals. Nausea and vomiting can be there, and the pain may lead to the right shoulder in person with gallstones. And this presence of gallstones can lead to acute cholecystitis due to cystic duct obstruction. So inflammation of the cystic ducts, or maybe the gallbladder is known as cholecystitis. So due to the presence of these stones that can lead to inflammation. Or choledocholithiasis. Choledocholithiasis leads to obstructive jaundice. Once now when there is obstruction of these ducts in the biliary tree will lead to choledocholithiasis, which may lead to obstructive jaundice. Also, it can lead to pancreatitis if it obstructs this ampulla of water. If these stones come and obstruct the ampulla of water, it leads to pancreatitis, inflammation of the pancreas. And also, it can lead to gallbladder carcinoma or the cholangiocarcinoma. So, carcinomas of the gallbladder are known as cholangiocarcinomas. Yeah. So, I'm almost done. Cholecystitis is actually inflammation of the gallbladder, as you saw here. Secondary to gallstones, so inflammation of the gallbladder is cholecystitis. What we'll be able to see in any inflammation of, we'll be able to see one area of hyperemia, especially now the mucosa, it will be hyperemic in nature. And remember, you can have acute or chronic cholecystitis. So what happens is that the gallbladder will be enlarged. It will have tense, it will be tense in nature, tense gallbladder. The surface will be hyperemic and covered with fibrin in acute cholecystitis. The whole of the gallbladder will be thickened and edematous. Edematous means it will be watery in nature. Then the lumen will contain turbid bile or pus. Then for chronic cholecystitis, it will be shrunken, fibrotic gallbladder, the end rigid wall because of continuous cholecystitis and mucosal atrophy. And what is the other thing that we'll be able to appreciate? We'll appreciate there is severe, the person will complain of severe right upper quadrant pain, fever, nausea, and vomiting, and then the person will have positive Murphy's sign, um, and also the concept of referred pain. So remember here, we have the gallbladder being supplied by nerves and other structures, nerves. So the gallbladder has nerves. So these nerves, because of the irritation, that pain will be referred to the right shoulder, giving us now that positive pain there. And then the complications will be because of the inflammation and pus accumulation in gallbladder, edema, gangrene of the gallbladder leading to perforations and peritonitis and fistula formations. Okay, 2 slides, then I'm done. Yeah, so 2 slides, then I'm done. So I think I can go to pancreatitis. So for pancreatitis, just by the name itself, so what is pancreatitis? Inflammation of the pancreas. And what I'll ask you, I would like you just to know the inflammation of the pancreas. So what is pancreatitis? Inflammation of the pancreas. There are two types of pancreas. There is acute pancreatitis and there is chronic pancreatitis. So what will happen? What will happen in a person with acute pancreatitis? In a person with acute pancreatitis, maybe only if you can mute kindly. What will happen is that in a person with acute pancreatitis, the person will have an enlarged edematous pancreas, areas of hemorrhages and fat necrosis, and also peripancreatic inflammation. And that is actually what you can see here. So this is the pancreas. It's inflamed in nature, as you can see here. Then it, in a chronic pancreatitis, the person will have shrunken fat pancreas, fibrotic replacement of parenchyma, and dilated irregular ducts and calcifications. So that's about it. Then we go to this same case of pancreatitis. Yeah, and then the last thing that you're supposed to cover today. Uh, okay, we talked about this, so allow me to skip this. Um, the next thing that you're supposed to cover today is actually pancreatic cancers. So pancreatic cancer is actually cancers of the pancreas, especially the head of the pancreas. So just by the name itself, pancreatic cancer is actually cancer of the pancreas. Most of the time affecting the head of the pancreas. So what is important is actually the morphology. So even if we cover the structure here, the morphology, what will you be able to see pathologically? The spread complications will not be important, but if you tell me the morphology will be good. So what will affect you'll see a mass in the head of pancreas. Yeah, so those are the features of pancreatic cancer. It will present with head of pancreas mass that is commonest sign in the head, firm gray white infiltrative lesion, compression of adjacent structures, such as common bile duct leading to an obstruction, duodenum leading to partial obstruction, and also it can lead to dilated biliary tree and gallbladder, known as covecinia sign. For the clinical symptoms, one, painless progressive jaundice, weight loss and anorexia. Remember these cancers or malignant features. Painless progressive jaundice, weight loss and anorexia, pruritus due to cholestasis, pale stools and dark urine, epigastric pain radiating to the back, which is a late feature. Those are some of the clinical features of the pancreatic cancer. Then we have spread as early lymphatic spread in regional nodes, hematogenous spread in liver, and then perineural invasion, which is severe, which will lead to severe pain and direct invasion of the duodenum and biliary tree. So the pancreatic cancer invades or spreads via lymphatic spread, hematogenous spread, perineural invasion, as you can have in the direct invasion of the duodenum and biliary tree. The other thing for us to appreciate is complications such as obstructive jaundice, hepatic failure, which is a late feature, cachexia, it's a malignancy, and portal vein involvement leading to portal hypertension. Yeah, so with that, mine is to wish you all the best. And if you have any question, let me know in the chat box of any question. And also feel free to do the necessary like, comment, share, subscribe. And that is for me a very big thank you. See you in the next one.